how's your microphone? I mean, like last week.
It worked fine.
Yeah? Okay.
Yeah. All right. Good morning, everybody. Can you hear me? All right. So, how are your studies coming so far? Good? Yeah, I know endocrine can be, has lots of complicated pathways, but that's why we're here. So, and we're going to try to explain as we go along. Anybody has any questions from your readings? Okay. So remember that you can approach myself or any of the faculty if you have any questions regarding some of the contents that we've talked about. So today we'll be talking about the pancreas and diabetes. Diabetes is a big part of the step one, and also in clinical practice, you're going to see a lot of diabetes. So we'll try to spend as much time as we need to make sure that the content is clear to everybody. So these are our learning objectives. So the first, let me turn down the light so it's... So the first, hope you guys don't go to sleep. So the first is just to look at the pancreas. This, an islet of the pancreas. As you can see, it has alpha, beta, and delta cells. Okay, the alpha cells make glucagon, beta cells make insulin, and then the delta cells make somatostatin. And the illustration just shows you how proximal the cells are. And how, we talked about paracrine and autocrine function. You can see that it's very easily, there will be lots of paracrine interactions between the different cell types and the hormones that they produce. And we'll delve more into each of these hormones in the subsequent sections. So insulin, we'll start with insulin. It's a hormone of abundance. So it often predominates when there's a lot of nutrients. Glucose, fatty acids, amino acids. And the purpose of insulin is primarily to build. Okay, it's an anabolic hormone, so it builds up the body. And one of the things about insulin is that, patients that take insulin tend to gain weight. Okay, that's because of that anabolic effect of insulin. So many, in clinical practice, you're going to see a lot of patients that complain that since they started taking insulin, they can't lose weight. And that's because when you take insulin, you have to eat to avoid getting hypoglycemic. And as you eat, you gain weight, you take more insulin because of insulin resistance, so it becomes like a vicious cycle. But the bottom line is insulin has anabolic effects. This is the structure of insulin, the amino acid sequence. Just for emphasis, like we talked about in the introductory lectures, the peptide hormones are made from DNA, message in the DNA through the messenger RNA, just like every other protein. They have the proinsulin produced in the ribosome, and then the proinsulin, and then that is processed in the endoplasmic reticulum, and then stored in secretory granules until the signal comes for insulin release. And then those granules are released, and you have insulin in the circulation. And insulin is produced with C-peptide. As you can see, it has an A chain, a B chain, and then a connecting peptide, okay? So, and the A chain and the B chain are connected through two disulfide bonds, and then there's a disulfide bond on the A chain. These are some things that you might see on your board exams, so just keep that, remember that, the structure of insulin. It has two disulfide bonds connecting the two chains, and a third bond on the alpha, on the A chain. Okay? And then the next, I put these questions for you guys to think about. Usually if I send out the slides, the idea is, those questions, as you go through the slides, it will help you to kind of think through some of the things we'll talk about. But what is the clinical significance of C-peptide? Why is it relevant?
It helps us differentiate between type 1 and type 2.
Okay, I'll take that. That's one of the things we use it for. Anything else?
It should be.
Okay, all right.
It's secreted in equal amounts as insulin. So if there, I guess that's how you would distinguish between type 1 and type 2, because in type 2 there should be normal or high levels of C-peptide.
Okay.
But in type 1, since there's damage to the beta cells, there should be low,
Okay.
low levels of
That is very correct. That is true. And that is, because you make insulin and C-peptide at the same equal amount, essentially, if there is, it tells you about endogenous insulin beta cell function. Okay? Anything else?
Tells us if the insulin if insulin in your body is made by the pancreas or if it's like synthetic insulin.
Good. So the second point is, the first is it helps you to distinguish between type 1 and type 2 diabetes to assess the function of the beta cell. And then the second point is it helps us to know if insulin in the body comes from the body or it came from outside. Okay? Because if it came from the body, you expect that the C-peptide should match the insulin when you measure the two. Whereas if it came from outside, okay, you expect that the insulin may be high because you took an injection, and when it's high, it will suppress the endogenous production if there is any function left, okay? So there's going to be low C-peptide if it is from outside. So C-peptide is produced in equivalent amounts as insulin. It can be used as a surrogate to assess beta cell function. So that's the first point. So that's, for example, if, in patients with type 1 diabetes that don't have beta cell function. Also, in hypoglycemia, which can be caused by too much insulin produced by the beta cells or by cells or by taking exogenous insulin, you can assess C-peptide to help determine the source, whether it's exogenous or endogenous. So these are the things that you guys talked about. So very, very well explained. So we're going to do some quick exercises as we go along just to keep us all engaged. You can scan the QR code with your phones. This is completely anonymous. We're not taking any, it's just to help us to drive our conversation. And then you can answer the question. So which of the following does not stimulate insulin production? All right, so we've gotten to let's see what you guys think. Okay, most of you got it correctly. So the correct answer is somatostatin, okay? And as a matter of fact, somatostatin inhibits insulin and glucagon secretion. So that's one of the actions of somatostatin. One thing you should remember is that somatostatin is one of those hormones that it kind of shuts down everything, essentially, in the endocrine system, okay? So it does not stimulate insulin production. Sulfonylureas are one of the medications used to treat diabetes. They do stimulate insulin production, okay? Glucagon also also stimulates insulin production because there's a feedback, there's a paracrine mechanism in the beta cell where it stimulates insulin secretion. Then amino acids, just like glucose and fatty acids will stimulate insulin production, and potassium as well. So most of you got it correctly. All right, and then, so this is the secretion of insulin. As you can see, there's the primary drive for insulin secretion is glucose. So when you have increased plasma glucose, the glucose goes into the beta cell, and you see there's a glucose transporter too. Okay, this transporter is really, there are different glucose transporters. So GLUT2 is gradient dependent. What does that mean? It means that glucose goes in if there is high enough glucose on the outside. So it's driven by the gradient of glucose between the extracellular and the intracellular space. So when the glucose is rising in the serum, then more of the glucose goes into the cell, into the beta cell. And the more that goes into the beta cell will now lead to, glucokinase activity that leads to increased ATP and depolarization, leading to degranulation of the insulin vesicles with insulin, leading to release of insulin. So response to high glucose leads to intracellular changes that lead to ultimately to insulin release that helps to bring down the glucose. And obviously, as you can see, potassium is intricately involved, and as potassium causes depolarization, and there is transport of glucose along with potassium as part of the action of insulin, and that has some clinical relevance as well. And on the right side, you see the different regulators of insulin secretion, nutrients, glucagon, cortisol, GIP, potassium, and some drugs, medications like GLP-1 and sulfonylureas. These are all, the green ones are the ones that stimulate, whereas the red ones are the ones that reduce insulin secretion. So hypoglycemia, fasting state, exercise, somatostatin, and then some drugs like alpha agonist and dioxide. In terms of insulin secretory patterns, so this is an illustration of if we measured our glucose, our insulin, plasma insulin level throughout the course of the day, this is what we're going to get, okay? As you can see, now if you don't eat lunch, you're not going to have a spike at lunch. It's just going to stay flat. So this is typically the response to, calories in the body. So depending on how much we eat and how much, depending on how much you eat can determine how much insulin is produced, okay? Another thing you notice is that the insulin is never zero, okay? It's always there. So that means that there is always insulin secretion. So there's background insulin, and then there's the insulin that is produced on demand when we consume calories. So that's important to understand, because that is the principle of treating diabetes, okay, by replacing insulin. You're trying to give a basal insulin for that background, and then some spikes, with the meals. So basal and bolus insulin regimens. And just for discussion, why do we think that the body makes insulin all the time? Why don't we just not make insulin when we don't eat? Why do we need to make insulin? Okay, I will accept that. However, the question then becomes, can't you use fat for energy? Can't you use which cells?
No, I wouldn't want to use fat for energy because of the risk of acidosis and the latent effects of that. Also,
okay.
Glucose is the best choice for the Krebs cycle and our regular metabolism.
Okay. And you can generate glucose from fat too, right? Mm-hmm. So the point is, the reason why you need, that is correct, but the full answer is that certain cells also prefer glucose. Because no matter what happens, you still make glucose. Okay? That's why you always have insulin. Because if there's no glucose, there will be no insulin. Right? Because that's the driver for insulin production. So you make glucose all the time from gluconeogenesis, from lipolysis, all the fat breakdown. Okay? And that because of that, you need to make insulin to take care of the glucose. But why do you need to make glucose? Because some cells prefer glucose, like the brain. Good. So the brain, red blood cells prefer glucose. So that's part of the reason why the body makes glucose, even though we are fasting. And that's why if you fast for a long time, you lose weight, right? Because the body breaks down everything to generate glucose, because some cells like to, prefer glucose for metabolism. So this is insulin action. There are two key sides to this, okay? The first side is on the left side, okay? So insulin binds to the receptor, The question is, what type of receptor is insulin receptor? What kind of receptor? Okay, so tyrosine kinase. So it's a surface receptor, tyrosine kinase, okay? So that's important to remember because, again, on your boards, you're going to get where they'll give you scenarios where they say something bound to the receptor and led to tyrosine kinase activity. You're supposed to know what is the, what triggers tyrosine kinase. Okay, and we talked about it in the first lecture. So, so it binds to the receptor, and the first action is, all those metabolic effects, which is, cell growth, so all the anabolic effects of insulin over here. And then also it has an immediate effect. You see another glucose transporter. This is glucose transporter number 4. Okay, so GLUT4. So it has a different action. Unlike GLUT2, which is on the beta cell, that, the passage of glucose through GLUT2 is driven by gradient. GLUT4 is insulin sensitive. So that means it doesn't matter how much glucose is outside. If there's no insulin, it's not going to open the channels. Okay, so it's insulin sensitive. So that's why, that glucose transporter, insulin binding to the receptor will lead to the translocation of the GLUT4 to the membrane so that glucose can go into the cells. So without insulin, no matter what's happening outside, you cannot get glucose in the cell. So the cells essentially will be feeling like there's no calories, there's no energy. So what does that do? It will trigger gluconeogenesis because the cells are trying to generate glucose. Okay, so that is the mechanism behind, things like DKA, for example, which you're going to see a lot in your practice or in your board exams. So it's a surface receptor, tyrosine kinase activity, IGF-1 and growth hormones. So growth factors also use the tyrosine kinase receptor family. These are some of the glucose transporters we talked about. GLUT2 and GLUT4 we've talked about. GLUT1 is, also, so the only one that's insulin sensitive is GLUT4. Everything else is sort of gradient driven, and you can look, you can look at this, but this is essentially how glucose gets into cells through the glucose transporters. So insulin action, so the primary sites, the liver decreases gluconeogenesis, okay, and encourages glycogen synthesis and lipogenesis. So it shuts down generation of glucose. In the muscles, increases uptake of glucose, and then glycogen synthesis and protein synthesis. And then the fat cells, lipogenesis, glucose uptake, and decreased lipolysis. So essentially, again, it's building up. It doesn't allow breakdown. In addition to the actions on those sites, it also stimulates the uptake of amino acids into cells, again, for bodybuilding, and also increases uptake of potassium ions into cells. Okay? Questions on insulin? Okay, so it's, again, the idea is to try to talk about this so that you can understand it, and I hope that, my goal is for you guys to understand this so that you don't, you should memorize some things, but the goal is understand it to the point that if you see it, you remember, so that, it's easier to follow and to remember things if you understand how it works. Go ahead.
For glue transporters, why are some organs sensitive to insulin, whereas others aren't?
Well, that's a good question. So, why are some organs sensitive to insulin and others are not? It depends on the organ. Some organs, it wouldn't make sense to make like red blood cell to need insulin for glucose to get in. You want it to diffuse freely, right? Because that's where it acts. Okay? Things like, and so it has to do with regulation, essentially, of, insulin and glucose metabolism. Okay? So in cells that are something like beta cells, for example, let's go back a little bit. So for the beta cell, it wouldn't make sense if glucose can diffuse freely, right? Because if it does, then you're going to make insulin all the time. So you have to have a high threshold for the glucose for glucose to move through the glucose transporter. So by having a higher threshold, you only release insulin when the glucose is high. Whereas on some other cells, like the red blood cells, you don't want to make it difficult for the red blood cells to get glucose. You want it easy, right? So because you want the glucose to get into the cells. Okay, so it depends on what the needs of the physiologic needs of the individual cells are. That's what drives those different transporters, which one is where. Okay? Other questions? Okay. So glucagon. So glucagon, contrary to insulin, is predominant during the starvation phase. So when there's no calories. Okay? So it's kind of the opposite of insulin. This is the glucagon, molecule, similar to secretin, GIP, and secreted by alpha cells, like we talked about, and it binds to surface receptors. Okay, so it's a peptide, and then uses second messenger, cyclic AMP. Okay, so cyclic AMP happens to be one of the more common second messengers for most peptide hormones. They regulated by, when there's fasting, hypoglycemia, amino acids, arginine specifically can increase glucagon, cholecystokinin, beta agonist medications, and acetylcholine. And then it's suppressed by insulin, somatostatin, excess fatty acids. Of course, hyperglycemia will suppress it as well. So when you have too much nutrients, it will suppress it. And then GLP-1 receptor agonist. So primary site of action is the liver, and glucagon increases blood glucose. Essentially, the clinical use of glucagon is in when in the hospital you're going to see it a lot. Patients that have diabetes and they're taking insulin and they have accidental hypoglycemia. Okay, you can use glucagon to treat hypoglycemia. Because glucagon will increase glycogen breakdown and lead to rapid mobilization of glucose through different mechanisms. All right, another audience participation question. So you can scan the QR code if you don't have it active. Which of the following is not a clinical manifestation of glucagonoma? So a glucagon producing tumor. So we're going into actions of glucagon here. Okay, we're going to move on. Let's see what you guys think. Okay, so most of you got it correctly. So obviously, glucagonoma means excess glucagon. So that obviously is not the correct answer. Skin rash is one of the manifestations of glucagon excess. It's a typical skin rash. And then obviously it can cause hyperglycemia. That's why we use it to treat. So by exclusion, even if you didn't, you figure it's weight gain. And, it goes with the effects of glucagon. Because it doesn't cause weight gain, it actually causes weight loss. Okay? And this is kind of for us to review the actions of glucagon. Any questions? Okay. So kind of to summarize insulin and glucagon, think about the fed and the fasting state. It's something that, it's always interesting to compare the two. The aim of the two, insulin and glucagon, is to maintain blood glucose levels within a normal range. So when we are fed, okay, there's a lot of calories, okay, and the physiologic response is to build and to store the calories, okay. So you try to move the calories, put it away somewhere, and insulin is the hormone that does that. And the key organs involved are the liver, the pancreas, adipocytes, and the muscles. And the process often is glycolysis, glycogenesis. So all of this is all the the synthetic anabolic processes in the body. And then the effect is to gain weight. Whereas in the fasting state, there's not a lot of calories. Okay, so the body tries to mobilize calories from other sources in order to maintain the glucose level. So glucagon is the primary anabolic catabolic hormone in fasting state, and helps to mobilize energy from other sources. The pancreas, liver, and muscles and adipocytes are sites of action, key organs involved. And then glycogenolysis, so breakdown, or gluconeogenesis, primary processes. And then there's also lipolysis, which involves a breakdown of fatty acids to generate energy, well, often leads to beta oxidation and ketoacidosis and things like that. By the way, you can have ketones, right, when you have DKA. But is there any other state you have ketones? Besides DKA in patients that have diabetes, is it possible for people that don't have diabetes to get ketones? I bet you've had ketones at some point, high ketones at some point in your life. Okay? So when do you get ketones? Huh? That is true. You can get ketones when you eat a keto diet. So that's, but suppose you don't eat a keto diet. When you fast, okay? When you don't eat, okay? It's just that you don't get to the, pathologic levels of ketones. If you don't eat, you have to generate energy, glucose. And anytime you have prolonged fasting, so you fast for, say, the whole day, the body is going to break down fat and, to generate energy, glucose. And you're going to generate ketones. It's not going to be too high, but it's going to be high, but it's not going to be high to cause ketoacidosis. So that's what you call starvation ketosis. Okay, so that is just it's the same pathophysiology. So, but how do you distinguish that from DKA? Well, in DKA, there is no insulin, whereas in starvation ketosis, there is insulin. So, because of that, in DKA, you're going to have hyperglycemia, right? Because there's no insulin. Whereas in starvation ketosis, you can actually have hypoglycemia, or very low levels of glucose. So, you're going to see the effects of insulin. Okay, so that's a simple way to distinguish the two. But again, that may be beyond what you necessarily need to know, but understanding the principle or the mechanism behind what is happening will help you to remember all of this. Sometimes you have patients that come in the hospital, they've been fasting because they've been sick, and their ketones are slightly elevated, but then you wonder, is it because they're fasting? Is it because they have DKA? So if you look at the glucose and look at other parameters, that can tell you, what's going on. Okay? So that's how, but you need to understand what is really going on to be able to make the interpretation. All right, so we're going to diabetes. So this kind of overview of, insulin, glucagon. The third hormone in the pancreas is somatostatin. It's pretty straightforward. It shuts down everything. There's not, there's a small section in your textbook. You can review that, but there's not a whole lot about somatostatin. Other than it, and inhibits many endocrine systems, and it's used for, treating different functioning states of the endocrine gland. Okay. Any questions so far? Okay. So diabetes. So this is diabetes diagnostic criteria for diabetes. Okay. This is important to know, based on the A1C, the fasting glucose, 2-hour oral glucose tolerance test, and then the random glucose. A1C, what is A1C? Glycosylized hemoglobin, okay? But in the red blood cells. Okay, so that's a more complete answer. So it's non-enzymatic glycation, okay, of hemoglobin A. So that's A1C. So, and it's non-enzymatic, so which means that it doesn't depend on any enzyme. So if the glucose is high, it gets glycated on the hemoglobin A. And when you measure A1C, it tells you how, because it's dependent on how much glucose. So the higher the glucose and for the longer the period, the higher the A1C. So we use A1C all the time in clinical practice. It's probably one of the most frequent tests that I measure every day that I see my patients with diabetes, because it tells you over the preceding 3 months, what's the average glucose. Okay, there's actually a correlation between the actual A1C and what the glucose average over the previous 3 months is expected to be. Okay, so that's important to know. You're going to see it a lot. And A1C and for diabetes, for diagnosis of diabetes, A1C greater than or equal to 6.5 is considered diagnostic. Okay. If it's between 5.7 and 6.4, that is pre-diabetes. Okay. So that is the range. So remember, over 6.5 A1C, greater than or equal to 6.5. Fasting glucose. So this is glucose you get in the morning. Okay, so you go to bed, you don't eat anything after dinner. You wake up first thing in the morning and go to the lab. So that's fasting glucose. Normal is less than 126. Okay, so non-diabetes range is less than 126. Pre-diabetes is between 100 and up to 125. Okay, normal glucose, non-diabetes, no pre-diabetes is less than 100. Okay, so that should be easy. So less than 100 is normal. More than 126 is diabetes. Okay, and then 2-hour post oral glucose tolerance test. So this is a test where you give oral glucose, 75 grams of glucose. Patient takes it, and you check the glucose at 1 hour and at 2 hours. Currently, we use the 2-hour number to make the diagnosis. So if it's more than 200, so if you take 75 grams of glucose, check the glucose 2 hours later, and it's more than 200, that is diagnostic for diabetes. If it's between 140 and 199, then that is pre-diabetes. Okay? And then finally, random glucose. So there's no random glucose criteria for pre-diabetes, but for diabetes, if it's more than 200 or equal to 200 with symptoms, then that is diagnostic. So if a patient comes in the hospital with symptoms of diabetes, of hyperglycemia, and their glucose is 250, that is diagnostic. Okay, so what are those symptoms of hyperglycemia? Okay, all the polys, so polyuria, polyphagia, polydipsia, and all that. Okay, so remember that. So if a patient comes with those classic symptoms, then and their glucose is more than 200, then that is also diagnostic. Type 1 diabetes. So I think you guys, we already talked a little bit about this, and I'm glad that you read ahead of time. It's always very, very helpful to review the content before the class, because then you will follow along much, much easier. So this is just showing what happens over time in the course of the diagnosis of type 1 diabetes. It's believed that there is some genetic predisposition, okay? And that genetic predisposition is then triggered by some environmental factor. It's believed that could be like a viral infection, maybe. And after that infection, there's that activation of the immune system that leads to autoantibody insulitis, so destruction of the beta cells. And as the beta cells decline, it gets to a critical point where, the beta cell mass is inadequate to keep up with insulin requirements. So therefore, it starts to have less insulin that the body requires. So that leads to clinical hyperglycemia and then diabetes. And ultimately, there's almost complete loss of the beta cell as a result of the autoantibody activation. And then these are the antibodies. In clinical practice, these are the antibodies we test type 1 diabetes. So if a patient comes in the hospital, for example, and they have hyperglycemia, and they get discharged and they come to the clinic for the first time after the initial diagnosis, okay? Then we sometimes screen them for antibodies, okay? So what are some things that might make you screen somebody for type 1 diabetes? Suppose they have a new diagnosis of diabetes. What are some things that might make you suspect type 1 diabetes? What are some clinical factors, either by how the patient presented or their physical appearance, or is there anything that you see that might make you suspect type 1 diabetes? Good. So if they came in the hospital with ketoacidosis, you have to suspect type 1 diabetes. Okay. If they are always fatigued, some of those, fatigue is often a very non-specific symptom, but yes, but it's very sensitive. Many times they'll feel fatigued, but it's not very specific. Okay? Anything else? Good. Weight loss. So if you're losing weight, and that's because compared to type 2 diabetes, where it's obesity-driven, right? Type 1 they're usually not very heavy at the time of diagnosis. And that's because you don't have insulin, okay? The body, glucose cannot go into the cell, right? So you go to gluconeogenesis, that leads to ketoacidosis, right? But where does gluconeogenic precursors come from? Fat cells, proteins. So you're going to lose your weight. So oftentimes they're slim and thin, and they're very insulin sensitive because they're not resistant. Okay, so those are things to keep in mind. So if you have a patient, so again in clinical practice, thin patient comes with new onset diabetes. If they are younger, right? Often it's younger age, not when they are 60. Although you can have type 1 diabetes in the 40s and 50s. There are some scenarios, different autoimmune activation of destruction of the beta cells, but more commonly they are younger, which is why they used to call it juvenile diabetes, which we don't use anymore because we recognize that, older people, adults do get type 1 diabetes as well. Okay? And then this is TrialNet. TrialNet is an ongoing international trial evaluating for antibodies in relatives of patients with type 1 diabetes for early detection of susceptibility. So we have because we know that patients with type 1 diabetes is genetic, is more genetic than type 2 diabetes. So there is genetic predisposition like we talked about. So if you have a patient that has type 1 diabetes, with this TrialNet, we have one of the sites here, the patient can bring their families, their first-degree relatives, to come and be screened if they have those antibodies. Because remember that we looked at the antibodies, there's some period of genetic susceptibility. So if you can identify patients that have susceptibility, you can follow them closely so that you can detect it on time and actually there's a new treatment that you can actually start when they start to go into a little bit, when you start to have antibody destruction and some dysglycemia. There's the medication that you can use to slow down that progression and maybe make this curve a little bit longer so that the time to clinical diagnosis is prolonged. But that's the whole point of the TrialNet. And teplizumab is the medication. It's FDA approved to treat, to slow progression to clinical diabetes in those with positive antibodies, okay, or stage 2 type 1 diabetes. You don't need to know that, but that's just, clinical information that if you're interested to kind of be aware of. You don't need to know that at this stage. Let me put it that way. At some point, you know about that. All right. Other autoimmune conditions associated with type 1 diabetes. So autoimmune thyroid disease, about 15 to 30%. So things like Hashimoto, Graves' disease. These are common in patients with type 1 diabetes. So again, in your exam or in clinical practice, you're going to see, if they give you someone with type 1 diabetes, if they're trying to help you to distinguish between type 1 and type 2, they tell you somebody that has thyroid disease, has Hashimoto thyroiditis, comes in with, fatigue, and they are peeing a lot, and they say, what's the most likely, cause of the symptoms, and they give you the glucose. You say whether it's type 1 diabetes, type 2. So you should know that when you have a cluster of autoimmune conditions along with diabetes, it's probably going to be type 1. And then celiac disease is another pernicious anemia. Vitiligo, also, if they give you if you see a picture of a patient that has vitiligo, okay, and they're having hyperglycemia, that's type 1 diabetes on your exams. Or any other autoimmune condition. So vitiligo is an autoimmune condition. So think of autoimmune processes when you see that. So treatment of type 1 diabetes. Again, this is something we went over this previously. So this is, again, you're trying to mimic what the body does, the physiology. So you give basal and then bolus, meals. And how much you give, they don't have to be equal. It all depends on how much you eat. Some patients eat more, breakfasts than dinner, or some eat more dinner. So so you can give like 6 units before breakfast, lunch, and then 8 units for dinner of rapid-acting insulin. So the bolus is rapid-acting because you want it to go in quickly and go out quickly. You don't want it to stay for 24 hours, okay? Whereas the basal is the longer-acting insulin. You want it to stay steady, a slow release over 24 hours. But the bolus is quick in, quick out. Okay, so that's where you have the rapid-acting insulin and then the long-acting insulins. So again, depend on how much calories are consumed, because as you can see, the body makes insulin that matches how much we eat. So the same thing applies. How much we need to inject exogenously depends on how much we eat as well. Okay, so we do that adjustment to account for the caloric intake. Insulin action. So irrespective of the type of insulin, once at the receptor, the metabolic effect is equivalent. And the why I put this here is for you to recognize that even though when you're looking at insulin, there are different types of insulin. There's basal, there's bolus, there's glargine, there's degludec, there is Humalog, Novolog. All of these different insulin, once they get to the insulin receptor, the action is the same. So all we're doing is we're trying to alter the speed with which it gets to the receptor. Because people that don't have diabetes, you don't make different types of insulin. It's one insulin that you make, right? So all the body does is you alter the secretory pattern to match the physiologic needs, okay? So the same thing, we do the insulin analogs are molecules that are altered slightly so that it behaves differently when you inject it subcutaneously to kind of alter how quickly or how slowly it gets to the receptor. Make sense? So just remember that. If you change the insulin and it becomes something else, then it won't bind to the receptor. So it has to be able to bind to the insulin receptor to have the action. So think of it as, I use money as an example, okay? If you have cash, so you can have two people. One person has $1 million in retirement stock or whatever, okay? Another person has $1 million as cash. Which is more available, cash or stock? Cash. So that's the difference. So you can have, so the question is, how quickly can you get the money to your hand to spend it? Okay? So the long-acting insulin is like stock. They're waiting somewhere, it takes slowly to release. Whereas the rapid-acting is like cash at hand. It's right there, ready to spend. Okay? You give it, you spend it, and it's gone. So that's kind of how an analogy you can think of used to understand the different insulin profiles. The difference between human and analog insulin, I think we kind of talked about this. So analogs are modification to the insulin to change how it behaves. So you're modifying I know I've said one thing. I've said you can't change the insulin. If you change it, it can't bind to the receptor. But I'm now saying that you modify the insulin. So what does that mean? You can the part of the insulin that binds to the receptor cannot be changed. Okay, so if you alter because it has the A chain and the B chain. So all the changes that go to the insulin molecule doesn't affect the binding receptor site. And only there are some non-essential, I won't say non-essential, but non-binding parts of the insulin molecule that you can alter. So you switch one amino acid for another, and that leads to different profiles of the insulin. So this is kind of an illustration that I added in the slides. As you can see, the different aspartate, Lispro, glulysin, it involves switching like lysine for aspartic acid in here for the glulysin. Okay, Lispro, you switch to amino acid lysine and proline, and so essentially you switch the amino acids around, and by doing that you change the way the insulin behaves when you inject it subcutaneously. Okay, so normally if you inject insulin, you want insulin to be in monomeric form. So monomeric form is the form that is absorbable. Okay, but usually when you inject it, some can have hexamers, big molecules. So by changing these amino acids, you change how quickly it breaks down to monomeric form for absorption into the capillaries and then into the circulation. On the other hand, something like glargine, for example, has 24-hour kind of action profile. It's the same insulin molecule. It's just that, the alteration to glargine makes it to be more acidic, so that once you inject it, it precipitates under the skin. Okay, and by precipitating under the skin, it's kind of slowly released into the circulation over 24 hours. So you can slow down or make it quicker, as This is the action profile of different insulins. I think at this point, most times we use this group of insulins, the aspartate, Lispro, and the glulysin, because they are quick. When we eat, as you can see, their action profile is quick up and quick down. And that's what you want. You don't want something that lingers for a long time if you're using it for mealtime adjustment. You want something that's in quick, out quick. On the other hand, the longer-acting insulins, the glargine and the degludec, are the ones that we use most commonly for basal. The NPH and the other, are not as preferable, because even though NPH is considered a long-acting insulin, okay, but you can see that it has a peak, so it can cause hypoglycemia. Even though you're using it for basal, but it does peak, okay. So the only time we generally use NPH, or usually, is when there's cost. It's a cheap insulin, so sometimes we use it because it's cheap. In patients that don't have good insurance or don't have any insurance at all. And move on. And this is the actual action profile. If you don't need to memorize this. This is just to give you an idea of the onset, the peak, and the duration of action of different insulins. As a matter of fact, there is a new insulin, Icodec, which has an action. It's a weekly injection. So again, just FYI, in case, for your boards, and they usually don't give you things that are kind of brand new. So, but you should know that there is a weekly insulin that's out there that just got approved not too long ago. Adverse effects of insulin, so hypoglycemia, that's obvious. Weight gain, okay, we talked about this already. You can get hypokalemic, especially when you're treating someone that has like DKA, for example. During the management of DKA, we try to watch the potassium very closely, because you're giving large amounts of insulin. So that can lead to shift of potassium into the cells, and that can lead to hypokalemia, okay, because of that effect of insulin. And then, other things like injection site reactions. Sometimes your patients will complain about that. But as far as allergies, it's very uncommon to have like allergic reactions to insulin. It is possible, depending on what is used to make the insulin, but most people don't have allergies, but they do have injection site reactions, which is why we ask our patients to rotate their sites. So don't keep giving your insulin the same spot. Otherwise, you're going to get, damage to the subcutaneous tissue, lipodystrophy, and all kinds of reactions. So you ask them to rotate, do the quadrant, or, rotate at different sites in the arms and all that, so that you can rest the different areas before you use them, multiple times. Imagine someone that has type 1 diabetes. They have to take insulin 4 times a day, depending on whether they're doing injections, if they're doing injections. So if you have to take 4 shots a day, and if you give it all at the same time, every day, think about that. So in a week, you're going to give 28 shots in one spot. Because if you rotate it, it makes it easier. By the time you come back to the original site, it's already recovered from the injection. So that's important. Talking about concentrations of insulin, this is another thing that, another concept you need to kind of understand as well. Insulin traditionally has come as U100. Okay, that means for 1 ml of insulin volume, you have 100 units. Okay, so if you want to give, say, 50 units, then you give half a ml. Okay, but you do have concentrations up to 500 units per ml. So that's U500. Okay, there's 300 units per ml. 200. So these are a reflection of what is happening in our society. People are getting more insulin resistant. So if you give U100, suppose there are patients that take up to 300, 400 units of insulin. So if you're going to get 400 units of insulin, 300, 200 units of insulin in one injection, you're talking about 2 mils of injection. That's not a sub-Q injection. That's almost like a depot. You're going to give a large volume. That's not ideal because it's going to cause all kinds of injection reaction, poor absorption, and altered action profile of the insulin. So by making it more concentrated, so suppose you want to give 200 units. Well, let's just make it simple. 500 units, okay? If you're going to give 500 units, with U100, you're going to give how many meals? 5 meals, right? It's 100 units per meal. So if you want to give 500 units, you're going to give 5 meals. Whereas if you use U500, how many meals would you give? 1 meal. Okay? So that's why the concentration matters. So if it's more concentrated, you give less volume to get the same amount of insulin. Okay? So again, these are things you should just know because you're going to see insulin, you're going to say U100. What does it mean? That's why you have those concentrations. All right. Insulin delivery forms. It comes in vials and syringes. We still have vials and syringes. We don't use them a lot, but there are still some patients that do vials. As you can imagine, it's cheap, but it's not as convenient because to do a vial, you have to, to do a syringe, you have to, inject, put the syringe in the vial and draw up the insulin and make sure that it's, measured correctly using the syringe, which is not ideal. There are lots of prone to errors. It's not convenient. Imagine, you have to take insulin. You're eating lunch in a restaurant. You have to take out your vial and you have to draw it up, and everybody's like, "What's she doing?" or "What's he doing?" So, but on the other hand, the pens are convenient. They are discrete. The pens are pre-filled, so they're pre-filled with insulin. You dial up. The top of the pen has a knob where you dial up how much insulin you want to give. If you get to the number, say you want to give 10 units, you dial to 10. Then you put the needle tip, then you inject. So you can see that you don't have to draw up anything. So it's obviously more accurate. It's more discreet. It's more convenient. And, of course, many patients prefer that because, it encourages compliance. But it can be more expensive. I mean, not as exorbitantly expensive now compared to before. Pens are generally considered probably the standard of care now. In the past, we used to have insurance that say you have to do vials, but there's no insurance that insists on vials these days. There's always an option to do a different kind of pen. And then the third option are pumps, which again is sort of beyond what at this point, but insulin pumps are. Their devices, essentially what the pump is you have insulin that is preloaded in a device, okay, and then the device has an algorithm that determines how insulin is released. Okay, so in this case, you're trying to act essentially as a pancreas. The only difference is that depending on how the pump is set up, it might not have any feedback to the pump. Now, we have pumps now that have sensors. So they work with sensors. So the sensor tells the pump, this is the glucose, so this is how much insulin you should give. So the pump is regulated by the sensor. But there are pumps that are not. But again, for most patients with type 1 diabetes, we're moving to the point where the pumps are getting essentially a closed-loop system, where there's a connection between the sensor and the pump, and there's minimal input from the patient. in order to manage the pump. But as you can tell, it does improve outcomes because it's much more convenient. And limited use in type 2 is getting more in type 2 diabetes now. It's more complex because you're talking about, using a device that has an algorithm that you have to put, numbers and, the way the pumps work is if you're going to eat, you need to announce your meal. You need to say, hey, I'm eating this much calories because there's no way the body will know. There's no way the pump will know that you're eating. So if you say, I'm eating, say, 50 grams of carbohydrates, okay? The pump is programmed to say, for every 10 grams of carbohydrates or for every 5 grams of carbohydrates, give 1 unit of insulin. So if you tell the pump I'm eating 50, then the pump will give you 10 units for that meal. So that's how the pumps works for like boluses. Okay? I don't know, I hope that makes sense, but again, this is beyond what you need to know. But just know that there are pumps, insulin pumps that help with insulin delivery. Obviously, they are more expensive. Then there is inhaled insulin, which is not, it hasn't really caught on, but there is an option to inhale the insulin. Because the insulin can be absorbed through the pulmonary capillaries, okay? So that is it's supposed to be the fastest acting insulin because it goes straight into the capillaries. It's not like you don't have to absorb it or anything, it goes straight in. So, but it's not very popular. As you can imagine, patients that have respiratory problems probably will not be ideal for this kind of insulin because of the possible worsening of, respiratory problems. Okay? So this is A1C, again, non-enzymatic glycation of hemoglobin A. Okay, that's important to remember. And it reflects the average blood glucose over the preceding 3 months. And this is the chart I mentioned to you that, where you can correlate the A1C with the glucose. Okay? So, again, you don't need to memorize this, but just have a general sense. You can see that A1C of 6 is equivalent to the glucose of 126, which is the threshold for what? What's 126 glucose? What threshold is that? Huh? Yes, for diabetes diagnosis. Okay, so fasting glucose of 126 or higher is diagnostic for type 2 diabetes. So here, A1C of 6 is equivalent to fasting glucose of 126, average. All right, we'll do a quick poll here. Which of the following parameters is not elevated during DKA? Okay, just going to move on so that we can get to our break. Okay, excellent. So most of you got it correctly. So, and again, the point of these questions is for us to have discussion about the subject of the question. Okay, so this is more like for conversation and to review things. So during DKA, you have, obviously, potassium is often elevated. Okay, because of the lack of insulin action, so you can move potassium into the cell. So you have high potassium. Beta hydroxybutyrate is a ketone body, so that is obviously elevated. And then glucose obviously is elevated, both in the serum and the urine. So the GLUT4 activity is the one that is insulin sensitive. So, and in DKA, you have insulin deficiency or decreased insulin. So that is what makes the GLUT4 activity to be decreased. Okay, so that's why it's the correct answer. Do you want to take a break? Let's do like 5 minutes. We'll come back 10:05 and continue. Hey, how are you? All right, so let's get back so we can get to the end. So the next, so we'll talk briefly about DKA. So DKA is, you're going to see a lot of DKA in clinical practice. You're going to see a lot of DKA on your boards. And when you're thinking about DKA, the thing to remember is that, again, it's all dependent on how insulin acts. We already talked about this kind of, when there's DKA, there's not enough insulin, right? That's the primary reason for DKA. So this happens in patients like that have type 1 diabetes, so they don't make insulin. So because they don't make insulin, and if they don't get insulin injection, then the body goes into a state of, essentially an insulin deficient state. And when that happens, you have the body the cells don't get enough glucose because the glucose transporters, for one, don't go to the cell membrane so that glucose can get into the cell. So you have hyperglycemia, but intracellular hypoglycemia. And what does that do? It triggers the body's, the cell's response to try to generate glucose. So it tries to, break down fats and proteins to generate glucose. And that's gluconeogenesis. And then glycogen breakdown, lipolysis. Lipolysis leads to production of free fatty acids that body uses to generate glucose. But also those free fatty acids can lead to sort of an insulin resistant state and, cytokines. All of these worsen the DKA clinical presentation. So it's important to recognize and understand what is going on in DKA. You're going to see a lot of DKA, in like I said, in your clinical practice, depending on which direction you go, but you're going to run into it all the time. And but again, the importance also remember that it's not just about the glucose, because when we're treating DKA, for example, during the treatment of ketoacidosis, you often have the first thing that corrects is the glucose transporters going to the cell membrane. Okay, so many times when you're treating DKA, the glucose corrects. So the hyperglycemia normalizes quickly, but you still have acidosis. Okay, so it's really important to understand what is really happening in the background, because if you just focus on the glucose, okay, you might miss an active DKA, an ongoing DKA, because you have to look for the resolution of acidosis to make sure that you have fully, that diabetes has fully, the DKA has fully resolved. And the acidosis, if the acidosis is still not resolved and the glucose is come to, down to 100. So what do we normally do in that scenario where the glucose corrects before the acidosis is resolved? What do we normally do when we're treating DKA? Does anybody know? So I'll give you the scenario again. So you're treating a patient for DKA. They came in with hyperglycemia and ketoacidosis, right? You start normal saline fluids. You give them insulin. Again, but as you're giving them insulin and monitoring the electrolytes, their glucose starts to go down, okay? And it goes down to like 100. But then they still have acidosis. They still have, and the beta hydroxybutyrate rate is still detectable. So what do you do in that scenario? What did you say?
You have to administer glucose.
Yes, so you give glucose. Okay, because why do you have to give glucose? Because you want to keep giving insulin. Okay, so the only way you can keep giving insulin is to keep giving glucose. Okay, so because only insulin can resolve those ketoacidosis. So if the glucose corrects first, then you go to, you give glucose exogenously, and then continue giving insulin until the acidosis resolves. Okay, so you guys are already like in step 2 you have a jump start to step 2. This is not, so, but just understand what is happening, okay? So when you're treating, because in real life, this is what you're going to see. You're going to see patients with DKA. If you look at the DKA protocols, they give you, if the glucose is less than 200, you're supposed to switch the fluid from normal saline to dextrose, D5 normal saline or something, so that you can keep giving insulin until the DKA is resolved. These are some of the what happens in DKA. Again, this is in the slides, but to recognize that gluconeogenesis requires all this. It's probably the liver is a key player, and triglycerides are broken down, so you have increased fatty acids in the circulation that again contributes to the whole pathophysiology. But that leads to gluconeogenesis. But in the process of that, you generate ketone bodies. And those ketone bodies lead to acidosis. And that acidosis causes, but the problem is, even with that, it still don't correct the problem because, there's still no insulin. So even though you're breaking down the fat and the protein to generate glucose, the glucose still cannot get into the cell. So the problem is never solved until you actually intervene. So you give fluids and give insulin and monitor electrolytes, then that's how you treat DKA. But it will not resolve, unless there's an actual intervention, which is why, again, it's one of the acute complications that can, cause mortality in patients with type 1 diabetes. And these are the ketone bodies. Again, acetone is easily goes into the pulmonary system, so which is why you can have the fruity, breath. So again, buzzword. If you hear fruity smell, that's ketones. That's type 1 diabetes in DKA most of the time on your blood exams. And then, but you also have the beta hydroxybutyrate but the acetone is easily cleared in the lungs. Yep. Have I smelled it? Not in clinic, usually in the hospital, yes. Yeah. Usually more common in severe DKA. These days, many times when you have DKA, it's usually like the early stage because, there's access to healthcare. So most people, once they start feeling bad, they come to the hospital. But yes, you do, yeah. But I'll bet you on your boards, you're going to smell it. You're going to see it on the boards. They're going to give it to you. So just know that it's there. Yeah. And then potassium, again, this is what happens with potassium. Insulin regulates the activity of the sodium-potassium pump. So, in the absence of insulin, that pump is not working. And then when you give insulin, potassium now moves into the cell. So, but serum potassium is usually normal or elevated because of the absence of insulin. You can't move this potassium into the cell. So it sticks around. And many times it's actually cleared in the urine. So, which is why it's really important because once you start treatment, so before treatment, potassium is high because you can't move into the cell because there's no insulin. So what happens to it? There's glycosuria, right? And as you're peeing out the potassium. So when you start treating, DKA, you start giving insulin, the potassium now whatever potassium that is left, start to go into the cells. So when that happens, it can lead to hypokalemia. So it's important to understand that. So one of the key clinical considerations when treating DKA is to monitor the electrolytes, especially potassium. Because if you don't monitor potassium and you give insulin without correcting a low potassium, it can precipitate hypokalemia and cardiac arrest and all kinds of complications related to hypokalemia. So it's really important. But again, this is, more like clinical management, but it's understanding what is happening, will help you to remember all of these as you move forward. So in summary for DKA, there's insulin deficiency. Glucose is unable to enter the cells. So this triggers counter-regulatory hormones. So things like, what are some counter-regulatory, we can talk about that later, but things like, glucagon, cortisol, growth hormone. These are some counter-regulatory hormones that try to mobilize glucose. So increased gluconeogenesis and catabolism results in ketone bodies and metabolic acidosis. And then hyperglycemia causes osmotic diuresis. So that's another, again, because there's high glucose, as the glucose is trying to go through the urine, it draws water with it. So there's osmotic diuresis, okay? So you're losing water with the glucose. So that's why there's severe dehydration, okay? Because of the effect of, hyperglycemia going in the kidneys. And then there's also hyperkalemia results from insulin deficiency, okay? So, but when you correct the insulin, you can have hypokalemia, okay? This is where we're supposed to have our break, but anybody need an extra break? Okay, let's go on. All right. So the next is obesity and type 2 diabetes. I'll pause. Any questions so far on type 1 diabetes? GKA, type 1, these are all, your textbooks do a good job of, kind of summarizing some of this. So if there's something that you come across, just reach out to me or any of the faculty, or you can check on the textbook to review some of these concepts if there's anything that is not clear. Okay. So type 2 diabetes, obesity is excess body fat resulting in adverse health outcomes. There's a term called adiposity-based chronic disease, and the point of that is to recognize that obesity is not just, being fat, okay, like we think about. Obesity is a metabolic problem, okay? So the term adiposity-based chronic disease is supposed to change our mindset. Instead of thinking of it like, oh yeah, obesity, to think of it as it's a problem, okay? And adiposity-based chronic disease has several components, which we'll talk about. And it's just to recognize that there's more to just the fat. The fat is actually a metabolically active tissue. So let's see. Oh, that's an audience participation question. So which of the following hormones stimulates increase in food intake? These are not your first-line hormones, as you can tell. These are the less common hormones that you see. Okay, good. All right, wow, almost 100%. That's good. So ghrelin definitely stimulates increase in food intake. So leptin is made by the fat cells, and it's a hormone of satiety. So there are pathways in the brain, in the hypothalamus, that regulate energy like hunger and satiety, and these different hormones have different interplay for that regulation, and which is again why thinking of obesity as not just someone just eating. It's more of there's a pathway, there's a hormonal explanation to that, and that needs to be considered in the treatment of obesity. Adiponectin is made by the fat cells, and it helps. It has an effect like insulin sensitivity and breakdown of fats and all that. Peptide Y and GLP are made in the gut, so and they have GLP-1. We'll talk about that later on, but obviously that's a big area these days. If you turn on the TV, you're going to see Ozempic and all that. These are all GLP-1 agonists, and we use that pathway to try to mimic essentially the endogenous GLP-1s. And peptide Y is similar to GLP-1 made in the gut, and these are all hormones that send signal to the brain to say that, hey, I'm full. So if you take it, even when you don't eat, your brain will think you're full. That's like one of the key mechanisms how they work. So by doing that, it makes you feel less hungry, and you're less inclined to eat, to take a lot of calories. Okay. So BMI, is used for screening for obesity. It's estimated based on relationship between the weight and height. So for your height, the ideal weight is X. So depending on how much weight an individual has for their height, then that will be what will determine their BMI. These are the categories below. There's overweight, which is BMI of 25 to 29, and then there's obesity, which is BMI over 30. I'll put that as a caveat to this BMI. Individuals from different, specifically Asian populations have a lower threshold for those numbers. So instead of 30, I think it's 25 or 28 or 27 as a cutoff for class 1, and so on and so forth, because of the difference in body build for that particular ethnic group. And then, can you think of scenarios where the BMI may not accurately reflect obesity status? And then essentially, scenarios where the BMI is not accurate. Say that again. Good. So someone that's a bodybuilder. Because even though you might have a high increased weight, the weight is not fat, it's muscle. So, yeah, that's a good example. So bodybuilders, it's a good example of where the BMI doesn't tell the whole story. Okay? There's some also that people that have thick bones, that can also be a misleading, can affect the BMI. And there's also the concept of, metabolic risk. BMI sometimes doesn't really give you, it's the most widely available and most used parameter for assessing obesity. But we know that it's not the best, but it's because of the ease of use. That's why we rely on BMI as a screening tool. So that brings up waist circumference. This is a better reflection of, kind of metabolic risk. And as you can see, if you measure the waist circumference, and why is that important? Because it assesses central obesity. So central obesity is what tells you about visceral adiposity. Okay? And when you're talking about adiposity, like fat distribution, the fat that you have in the legs and the hands is not as important as the fat you have around your viscera. So that's the one that causes insulin resistance, and that's the one that causes diabetes. Okay, so which is why waist circumference is a better reflection of metabolic risk than BMI per se. So for male, it's supposed to be less than 40, and for female, less than 35 inches. So I think we already talked about this. So the clinical significance of visceral adiposity is that it is a direct correlation with, insulin resistance, diabetes. So the more visceral fat you have, the more the likelihood that you're going to have metabolic syndrome and, diabetes and all the other related metabolic complications. So metabolic syndrome, again, has 5 components. So waist circumference, which we talked about, fasting glucose more than 100. So that is anything in the pre-diabetes range. Okay. Dyslipidemia, so triglyceride greater than or equal to 150, and then HDL less than 40 for male or less than 50 for female, and then having high blood pressure. So either blood systolic of more than 130 or diastolic more than 85, or if you're taking medication and your blood pressure is below these reference ranges, that will qualify as well. So if you have 3 out of 5 of these, then that meets criteria for metabolic syndrome. And this is important because, we use it as a way to assess risk. And it's quite prevalent, if I walk around, I just look around my patients and, I try to screen. But the point is, these are all factors that drive metabolic diseases, diabetes, high blood pressure, high cholesterol, heart attack, stroke, it goes on and on. So identifying it early to make interventions is really important, when counseling our patients. So obesity, adiposity-based chronic disease. So it has different dimensions. So instead of thinking of it as just being, excess body fat, the thing about metabolic effect. So it can cause prediabetes, metabolic syndrome. It can cause type 2 diabetes. It can cause hyperlipidemia, dyslipidemia, hypertension, cardiovascular disease. It can cause, I'm sure I should update this, this should be MASLD and MASH. So that's a big area these days, fat in the liver, fatty liver disease. Okay, that leads to things like cirrhosis down the road, and that can lead to liver failure, okay? And then gallstones. And then there's reproductive. So having excess body fat leads to things like polycystic ovarian syndrome. You guys, did you do PCOS? No? Okay, I think that would be in the reproduction maybe. Then it can cause female infertility and male hypogonadism. And then biomechanical, this is from just the mechanical effect of the excess fat. Obstructive sleep apnea from the neck, airway disease, osteoarthritis, the weight of the body, stress incontinence, even peptic ulcer, acid reflux in the GI tract. That also can be related to excess body fat. And then psychosocial impact, things like depression and social stigma. Also, there are cancers that are related to obesity. These are all the different cancers that have been linked to obesity. So again, it's not just excess fat. There's some metabolic action or metabolic effect of the excess fat. And evaluating someone that has obesity, take a history, review the systems, do a physical exam. This is just routine clinical things that we do. Try to understand what have they tried to try to lose weight. Are they taking any medications? What are the options? To help to understand how to help. How to work with your patient, and then get some labs. Lipid panel, fasting glucose, A1C to screen for diabetes or pre-diabetes. Liver enzymes to check for, fatty liver or liver disease. And then assess for and treat cardiovascular risk factors. All right? So treatments, dietary, physical activity, behavioral therapy. These are all lifestyle measures. Pharmacotherapy, adjunct to lifestyle. So most pharmacotherapy will require that you do some lifestyle intervention before you start talking about medication. And then there's some indication for pharmacotherapy, based on the BMI criteria. This is sort of changing from time to time, but the bottom line is if you meet a certain threshold, then you can qualify for pharmacotherapy. And these are all the options available. These are the GLP-1s, the last three, liraglutide, semaglutide, and tirzepatide are GLP-1 agonists. Tirzepatide also has GIP activity. And then surgery, bariatric surgery is a big area. It's very effective for weight loss. These are the indications. You don't need to know the indications. Just know that it's effective. It can lead to up to 30 to 80%, loss of 30 to 80% of excess weight, and lead to resolution of comorbidities like hyperlipidemia, hypertension, even some resolution of diabetes, or pre-diabetes can resolve with post-bariatric surgery. And some complications, which again you don't need to know, this is more like for informational purposes. But these are the procedures on the right. You can see different things. And the point of this is to recognize that when you're talking about obesity and regulation of the weight, most of these procedures, what they do is they try to limit the size of the stomach. Okay, because the signal for, the balance in obesity, those hormones that we talked about, the gut hormones are produced in response to food, stretching the stomach. So if the stomach is, stretched out, it takes, a certain amount of food to fill it up before it stretches and sends those signals to the brain to stop eating. So if you make the stomach smaller, it stretches earlier with a smaller amount of food, so that you send those signals early enough before, so that you reduce the amount of the food that you eat. That's one of the mechanisms. There are other things that happens. Okay? I'll pause for any questions before we go on to type 2 diabetes. it's hard to talk about type 2 diabetes without talking about obesity. That's why, kind of give you a general overview of obesity. But obviously, type 2 diabetes is primarily driven by obesity. All right, so this is just to illustrate the relationship between obesity and type 2 diabetes. As you can see, as this is a heat map of the United States from 1994 to 2000 to 2015, and as the prevalence of obesity increases, okay, the prevalence of diabetes kind of matches almost superimposable the two different maps. So that's, again, to highlight the fact that obesity is a primary driver for diabetes. What is insulin resistance? Say that again. Okay. I mean, that's the opposite of resistance, sensitive. So, yeah. But that is correct. So, and what does that imply? The what? Okay, downregulation of receptors. I'll accept that. And that means that in insulin resistant states, you need to take more insulin to get the same effect. So if someone that has insulin resistance, you might need to give 50 units of insulin, whereas someone that's sensitive might need 10 units. Okay, so that's how that plays out in clinical practice. And that's the underlying mechanism or underlying pathophysiology for type 2 diabetes. And this is acanthosis nigricans. Again, if they show you a picture like this on your exams, that's clearly, trying to show you that there's insulin resistance. So that's one of the clinical features of insulin resistance. And this is the underlying pathophysiology, how obesity connects to insulin resistance. So obesity leads to, release of free fatty acids, adipokines, and inflammation, leads to insulin resistance. So really important, free fatty acids are one of the, drivers of obesity. Another thing that causes increased free fatty acids are things like hormones, like cortisol, growth hormone. That's how they work. They make, because of gluconeogenesis, they cause release of free fatty acids, and then that leads to insulin resistance. And because of the insulin resistance, the pancreatic islet cell start to work, because you need to make more insulin, right? So they work more than someone that doesn't have insulin resistance. So they're working twice or 3 times as hard, and that leads to compensation, but ultimately, compensation to increase the insulin secretion, but ultimately that leads to loss of failure of the beta cell, because you're working the beta cell hard for so long that ultimately will fail. And that leads to diabetes mellitus. This is kind of illustrating insulin type 2 diabetes in a kind of what happens to the glucose and the beta cell and insulin resistance over time. If you look at look at the bottom graph, you can see that as insulin resistance goes up, okay, initially there's a compensation by increasing the insulin level. So it matches the insulin resistance. But at the time of 0 points of diagnosis, okay? So this is 10 years before diagnosis. So this is to highlight the fact that before you actually diagnose somebody with diabetes, there is already, pathology going on for 5 to 10 years before that diagnosis, okay? And at the time of diagnosis, the insulin resistance persists, but the beta cells start to fail, okay? And when that happens, you start to have hyperglycemia. That's when the glucose starts to rise, okay, because you're not able to match the resistance anymore, okay? And that leads to, as insulin levels decline, resistance persists, you have increasing plasma glucose, okay? So that is just what happens. So again, recognizing that initially there could be you can see that there's actually increased insulin production at some point. Now, there's increased insulin production, but it's resistant, so there's a relative insulin deficiency. Does that make sense? So even though you're making more, you're matching the resistance, but, at some point, the resistance will persist, and you're not able to match the resistance anymore, and the cells will fail, then the glucose starts to rise. Okay? So there's a relative insulin deficiency, even though that you're matching it, ultimately it's going to lead to a relative deficiency. But, yeah, so this is important to kind of understand, and I think it's pretty straightforward, but is it confusing to any of you guys? Okay? And then risk factors for type 2 diabetes. These are some common risk factors. So age, more than 45. Physical inactivity. One of the things I see, a lot of my patients, because of the COVID pandemic, a lot of people started working from home. And once that happens, people tend to not move around as much. And, we're seeing more and more people having, diabetes as a consequence of that. If you have a family history of type 2 diabetes, okay, even though it's not genetic, but there's a strong correlation, between families, either because of environmental factors or because of some genes. There are still some genes, associated with type 2 diabetes, but it's not one specific gene. It's, multiple genes involved that I talked about. And then if there's high blood pressure, and then history of gestational diabetes in women. So any woman that had gestational diabetes means that think of pregnancy as a stress test for the beta cell function. So if you fail the test during pregnancy, it means that you have a threshold that you're close to the threshold for diabetes. So the risk is a little bit higher. And then those are the overweight also, obviously, like we talked about. And then certain ethnic groups, African American, Hispanic, Latino, American Indian, Alaskan Native, Pacific Islanders, and some Asian Americans. How do we, this again, to highlight the importance of lifestyle on preventing the progression of prediabetes to diabetes. So this is a study that was done, it's a landmark trial that was done in 2002. And they looked at patients that had prediabetes, and they grew them into three. One group had placebo, one group had metformin, and one group had intensive lifestyle modification. And they showed that, this is the cumulative incidence of diabetes. You can see that those that had the highest cumulative incidence are those that had placebo. Metformin was good, in delaying that, but the most effective was lifestyle. So lifestyle is a key part of, preventing progression from pre to full-blown diabetes. Complications of diabetes. This applies to both type 1 and type 2 in some respect because hyperglycemia causes kind of similar, but there are some differences. For example, when you talk about DKA and HHS, DKA is much more common in type 1 like we talked about. HHS is more common in type 2. And the difference between DKA and HHS, as you can see, the glucose is much higher in HHS. Bicarb is not, there's not much acidosis in HHS, okay? It's more of hyposmolar. It's a fluid and osmolality issue than anything else. And it's more common in type 2 versus DKA that's more common in type 1. Hyposmolar hyperglycemic state. What are some of the key defects? I think we already pointed some of them out, but can you think of anything else? So what's happening in HHS? What's like we talked about DKA, how you have the, no glucose coming into the cells, the gluconeogenesis, ketone bodies, hyperglycemia, dehydration, and all that. What's happening in HHS?
You're in a hyperglycemic state, so you're going to have increased osmotic diuresis and also be dehydrated and similar to diabetic ketoacidosis, but there won't be any ketones.
Okay, so that's correct. So there's severe hyperglycemia, Okay? That's the underlying problem. There's severe hyperglycemia, and that leads to increased osmolality, osmotic diuresis, severe dehydration, much more than you will have in DKA. And then, but you're still making some insulin, because this is in type 2 diabetes usually. So because there's some insulin in the background, you don't get it to ketoacidosis, because remember that the insulin shuts down ketosis, okay, shuts down the ketone body generation. So because of that, oftentimes you don't have you have minimal or no ketones in HHS. But there's severe dehydration, severe hyperglycemia, and it's more common in type 2 diabetes. And if you're going to get an HHS case, it's going to be like a 70-something-year-old man was found in their home, laying on the floor and things like that. They have diabetes, that's usually HHS. They're severely dehydrated. Whereas if you have a young 20-something-year-old with type 1 diabetes, with hyperglycemia, confusion, that's more like, some confusion, but, there's also confusion is more so in HHS than in DKA, but the other scenario is more like DKA. So presentation, symptoms, there's thirst, polyuria, weakness, weight loss, significant weight loss from dehydration, profound dehydration, hypotension, tachycardia, and altered sensorium, usually longer duration. So talking about days to weeks. And in HHS, you have hyponatremia because of the effect of the water from the cell going into the serum. It causes dilutional effect of the sodium. So oftentimes we have to correct for the glucose. So if the glucose is 600, you can do corrected sodium. So put that in the equation, and you can give you the actual sodium. So oftentimes when you have HHS present, you might have pseudo-hyponatremia. So it's false hyponatremia. Okay? And you can correct that by putting the glucose in an equation to give you the correct sodium. And then glycosuria, again, we talk about osmotic diuresis. The point of this is to illustrate that as the glucose level is elevated, as the plasma glucose goes up, okay, the kidneys will filter the glucose and also will reabsorb most of the filtered glucose. So there will be no excreted glucose. So as you're filtering, you're reabsorbing up to a threshold. Once you reach that threshold, the kidneys can no longer reabsorb the glucose. So it starts to excrete. So that's that Tmax, of reabsorption. So you keep filtering the glucose, but the maximum reabsorption threshold has been reached. So you start to have excretion of glucose in the urine. And one of the medications, which we'll talk about later, the SGLT2 inhibitor, all they do is they lower this threshold so that you can clear the glucose earlier instead of waiting till the glucose is about maybe 200 to start. Might lower the threshold to maybe 100 or 150 or something. Okay, so under normal condition, all filtered glucose is absorbed by renal tubules. I don't need to read this. I think this is in your text, but I've explained all of this. So talking about microvascular complications, you can have neuropathy, so peripheral, which could be peripheral or autonomic. So peripheral neuropathy is, what you have in the extremities, so something like nerve damage to the feet is the most common cause of, foot amputation, okay, because of loss of sensation, especially in Las Vegas, because here it gets hot in the summer. So patients with diabetes, sometimes because they don't have sensation, and you have concrete, we do desert landscaping, and there's concrete and, everywhere. So they walk out when it's 100 and something. The concrete temperature is 130 something. If the temperature is 110, the concrete temperature could be multiple, much higher than that. So if they walk out on the concrete, maybe you're going to the pool and you're walking around your pool. Sometimes they don't feel any sensation. So they get burns, from that. And that's one of the most common, if you rotate in the burn unit, you're going to see that, every so often during the summer months. So that's because of nerve damage. Okay, you don't have sensation because if someone that doesn't have diabetes goes out in the sun and it's hot, you're going to go back inside. But someone that has diabetes, that has severe neuropathy, will not feel the burn. And they walk around, and by the time they get in the house and they look at their feet, it's like, burnt. So that's really important. So that's one of the complications. And then autonomic neuropathy is things like, gastroparesis, for example, okay? Where you have delayed gastric emptying. Because remember that the stomach, you've done GI, the stomach has innervation, right? The nerves that innervate the stomach. Okay, you can have damage to those nerves, and if you have damage, you can have loss of the tonic activity of the stomach to move the food through the GI tract. Okay, and by having damage, patients that have this will complain of that they eat, but the food doesn't go down. And if you do like a gastric emptying study, so that's the study where they eat a certain amount of food that is radio labeled, it has some radioactive activity, usually eggs. They'll give them the food, and then they go back and they scan them after a certain amount of time to see if the food has gone through. You have delayed gastric emptying. Okay, so that is another another example of autonomic neuropathy. Also, you can have orthostatic hypotension, right? That's also autonomic neuropathy. So you can have things like that in type 2 diabetes and type 1 diabetes. Then retinopathy, that's damage to the blood vessels. So it can be non-proliferative or it could be proliferative, okay? Again, because of poor circulation in the eyes from the effect of hyperglycemia, you can have proliferation means that the cells, the blood vessels in the eye start to proliferate because they're trying to find other pathways to provide circulation. But by doing that, the proliferation damages the photosensitive tissues of the eyes. Okay, so you don't want proliferation of the blood vessels in the eyes because that's one of the ways that you have diabetic retinopathy. Okay, one of the treatments that we use, the two common treatments for diabetic retinopathy is laser photocoagulation, where they use laser to burn those vessels to prevent them from proliferating. Or there's VEGF inhibitors, vascular endothelial growth factor. They inject those in the eyes to prevent it. So this just highlighting the fact that retinopathy is a result of hyperglycemia, prolonged diabetes, issues with the blood vessels, blockage of the blood vessels, essentially leading to neovascularization. So new vessels, neovascularization is what you're trying to prevent. Of course, treating diabetes and controlling the diabetes and not exposing those blood vessels to those high glucose is the goal. But that is almost impossible to do, 100% for everybody. So most patients will ultimately develop some of these complications. So that's an illustration of where you have, neovascular proliferative diabetic retinopathy. And then nephropathy is the other common, so these are the third, where you have damage to the kidneys. It's the most common cause of end-stage renal disease in patients with diabetes. And because of the damage to the glomeruli, you have, albuminuria. So in clinical practice, we check microalbumin levels. It's in the urine. So if there's increased urine microalbumin, that will tell us that the degree of damage to the kidneys from hyperglycemia. And the peripheral neuropathy, I put this is glove and stocking because it's peripheral. It starts from the most distant part of the nerve and kind of moves inwards. So it's uncommon to have like a diabetic neuropathy that is starting in the knees. Usually we start in the toes and we kind of move upwards towards the middle. And the microvascular complications, these are straightforward, these are the bigger ones, big blood vessels. So micro is small blood vessels. Macro is big, things like heart attack and stroke. That's usually, when you hear, diabetes is number one cause of heart disease around the world. Everybody will know that. In fact, diabetes is what we call a cardiovascular risk equivalent, and that means that patients that have diabetes have risk of heart attack and stroke that is similar to patients that had previous heart attack and stroke but don't have diabetes. So having diabetes puts you at the same risk level as somebody that had a stroke or heart attack but never had diabetes. So, all right. Questions? I know some of these are, these are very relevant to what you need to know for, because complications of diabetes that's why we're talking about diabetes, right? Because ultimately it leads to pathology, and the pathology is what you're trying to prevent. So, review of diabetes, type 1, type 2. The etiology of type 1 is usually autoimmune, whereas type 2 is metabolic. Prevalence, type 1 is much less prevalent, about 10% of all diabetes, whereas type 2 is about 90% of all diabetes. And age of onset, younger, older. Body weight, we talked about this, thin versus obese. Insulin, often deficient in type 1, and then in type 2. I put variable because initially there can be insulin, but if it lasts for a long time, you can have, declining insulin, beta cell function over time, and that sometimes will mimic type 1 diabetes after several years of type 2 diabetes. And type 1 is insulin sensitive, whereas type 2 is insulin resistant. And the most common acute complication of type 1 is DKA, while type 2 is HHS. All right. I think we've ended a break, so let's have a little, and then we'll finish up the last section. Maybe we'll come back 10:05. Sorry, 11:05. All right, so let's get started again so we can finish, get you out for lunch. So this section is kind of an overview. You're going to have a more in-depth, pharmacology lecture with Dr. Raber on Monday, I believe, okay, to go over endocrine pharmacology. But it's hard to talk about diabetes without at least looking at some of the key medications that we use to treat diabetes. So that's why I kind of go over this section just to kind of introduce some of those treatment options, okay? So in terms of treatment, besides pharmacotherapy, there is lifestyle. That's the foundation of diabetes treatment. Okay, so lifestyle involves diet, exercise, and cardiovascular risk reduction. Includes things like smoking, avoiding smoking, avoiding stress. That can, so lifestyle is foundation. Then when we talk about medications, there is non-insulin medications. So these are often oral medications or injectables like the GLP-1s, the GIP, okay? And then you have the insulin. Okay, so as you know, in every diabetes, insulin will work because the underlying disease process in diabetes is not having enough insulin. So if you can give more insulin, it will work. But it's not always the best choice because you can still improve the economy of your own insulin before you need to take insulin from outside. So that's the principle of everything we do before we get to insulin, is to try to improve the efficiency of how well the insulin that we can make works. Okay? So all the treatment, anything that is not insulin, all it does is it tries to help you to either increase how much insulin you make or increase the efficiency of the insulin. And when I say efficiency, I mean sensitivity, right? You want to improve the response of the insulin, even though you don't have enough. But if you can dial down the resistance, right, you can increase the efficiency so it might not need to take more insulin. Okay, so that's the principle of treating diabetes. So when do we use insulin in type 2 diabetes? Examples. What are some scenarios we use insulin in type 2 diabetes? Anybody?
If it's extremely uncontrolled and the beta cell dysfunction decreases so much so that you aren't producing enough insulin with
Okay.
the other lifestyle modifications.
Okay, that is correct. So when there's severe hyperglycemia, okay, there's what we call glucotoxicity, and the body doesn't make insulin because the beta cells will essentially shut down because of very high glucose. So, and you need to rescue the beta cells, so give some insulin from outside, and sometimes they wake up and they can start, usually at the time of diagnosis of diabetes. That's usually type 2 diabetes. So when the sugar is very high at the diagnosis, but also during treatment. Okay, while you're treating a patient or you're treating and the sugar just keep going up with non-insulin medications, then yes, that's when another time you switch to insulin. Okay? Other scenarios is when, say, a patient that's taking oral medications goes in the hospital. Okay? Because the hospital, a lot of things happen in the hospital. Okay, for example, they might need to get a contrast, to do a CT scan. And if you're taking something like metformin, for example, you don't want to take contrast when you're taking metformin. Okay, or because metformin with contrast is, essentially contraindicated. Okay, so you don't want to be on metformin in the hospital because what if I want to do a CT scan and I want to give you contrast? So it's not ideal to use oral medications in the hospital. Another example is something like sulfonylurea that causes increased insulin secretion. But that's based on the assumption that you're going to eat, 3 meals a day, right? But if you take a sulfonylurea in the morning and suppose you're going to need to fast because you're going to do like a colonoscopy or something in the hospital, okay, or you're going to go for surgery the next, but because you took the sulfonylurea, it's going to make you to make insulin, whether or not you eat. Okay, so that becomes a problem. So that's why when you're in the hospital, we take out the non-insulin medications and just use insulin. That's what we do now. Okay? So that's another time that we use the insulin in type 2 diabetes. So in terms of approach, like we talked about, generally speaking, you start with lifestyle. Then most guidelines will recommend to start metformin. Metformin is cheap, it's readily available, it's effective. So we often will say do metformin. Then after metformin, you do other oral or injectable non-insulin medications. Then if you're going to go to insulin, we often start with just basal insulin first, okay? Just because if you give basal, you can preserve the function of the beta cells so that when you eat, you can have enough reserve to make some, depending on how much the portion is. But that's the rationale behind that. So basal alone, so that you can preserve the insulin, the beta cell function for the meal time, and then if that continues and the glucose keeps going higher, then you add the bolus to the basal. Okay, that's ultimately when you get to very decreased beta cell reserves. Now, for type 1 diabetes, just remember, it's basal bolus. There's no lifestyle, metformin, all of it. It's just, you go straight to basal bolus insulin, okay? Because they don't have any insulin, so they're insulin deficient, okay? So you can't boost anything. You can't improve any efficiency. There's nothing to improve, okay? So, but in type 2, you have insulin resistance. You can try to manipulate that in different ways to try to make it more, more effective. Okay. Then, when you're looking at pathophysiologic defects in type 2 diabetes, these are different organs that are defective, they don't function very well. You can have, the islet cell, for example. There's, decreased insulin secretion because of the dysfunction. Also, there's decreased incretin effect, which we'll talk about. Remember we talked about how the gut makes the GLP-1 and the peptide YY and all that. But in patients with diabetes, they don't make as much. They make less. And then you have increased lipolysis. Then there's increased glucose reabsorption. So kind of paradoxical. Okay, I have to plug in. So it's kind of paradoxical that even though that you have high glucose, the body is still reabsorbing the glucose. Let me just... And then you have, in the muscles, you have decreased glucose uptake. Again, because of the effects of insulin resistance, there's decreased uptake of glucose in the muscles. And then there's neurotransmitter dysfunction. This is where things like stress come into play. If there is too much stress, you have all these hormones like cortisol that are high, and they induce insulin-resistant states. And then hepatic glucose production, again, which is paradoxical, and that's because even though there's glucose floating around, it doesn't get into the cells. So the signal to the liver is that there is no glucose. So the liver side keeps trying to make more glucose. And then finally, back to the islet cell, the alpha cells, again, make more glucagon, okay, in diabetes. So these are all things that happen in patients with diabetes. And that's why it's difficult to control without specific intervention to reverse some of these. Interestingly, the GLP-1, which is one of the, I'm sure you guys have heard about, this. I'm talking about it again, but it's a big class, and they do affect several of these, different pathways, different mechanisms, which is why they're so effective in treating diabetes and these complications. I think I have to. Okay, so looking at the different class of medications, these are the main classes that, you should kind of know about. And I think the emphasis is to understand the mechanism more so than, I don't think you're expected to, you're supposed to know some pharmacology, but in terms of the background mechanism, it's important to know. But in terms of actually using it in clinical practice, that's much later, maybe in your step 2, as you go to your clinicals. But for now, it's really important to understand, how they work, the drugs in the class, what are some of the advantages and some of the adverse effects of this medication, because that will help you in selecting the right agent for the right patient. And we'll go over each of them quickly. Oh, we have an audience question. Which of the following pair of hormones will result in glucose lowering? Let's see what you guys think. All right, let's move on. So, okay, excellent. So most of you got it correctly. So insulin and GLP-1 and glucagon will not lower the glucose. It will actually increase it, and so will growth hormone. So growth hormone and glucagon will both increase the glucose. But insulin and GLP, obviously, these are used to treat diabetes. So to make sense that they will lower the glucose. All right, so the bigonides, mechanism of action, they reduce gluconeogenesis and improve insulin sensitivity, okay? What are some drugs in the class? Or what is the drug in the class? Metformin, okay? So that's the most popular bigonide. Advantages, we talked about it already. It's cheap and it's effective. And it's very, it's almost impossible not. In fact, if you go to Walmart, you can buy metformin. You can buy a year's supply for maybe $50 or something. It's very cheap. And then adverse effects, not a whole lot, but the main thing is to, if you hear lactic acidosis, that's often in context of use of metformin. You avoid it in kidney failure. As the kidney declines, you want to, avoid that. Again, these are things to know, and I think Dr. Raba will go over some of these with you as well, in terms of pharmacotherapy in endocrinology. Sulfonylureas are also interesting because, again, this is the same beta cell that we looked at previously, and you can see that this is GLUT2. They block the ATP-sensitive potassium channel, so depolarization and causing the depolarization and influx of calcium, okay, and then that leads to release of insulin, okay? The main thing about sulfonylurea is that, they don't depend on the glucose level, okay? Unlike the normal function of the beta cell where glucose comes in and, triggers all the processes. Sulfonylurea, once you take a sulfonylurea, it's going to trigger all of these processes as well, but it's not dependent on glucose. So it's really important that if a patient is taking sulfonylurea, they have to eat. Because if they don't eat, they're going to get hypoglycemic. Okay? So that's just the key thing to remember. So there are two medications that can cause hypoglycemia, or two classes, insulin and sulfonylureas, or the glenides. Okay? They work very similarly. Every other thing doesn't cause hypoglycemia by themselves. Okay? So if you have hypoglycemia, insulin or sulfonylurea or a glenide. So the drugs in the class, glipizide, glyburide, for example, these are some of the sulfonylureas, and then repaglenide and ateglenide for the glenides. The only advantage really is they're cheap, they don't really, that's the main advantage. They do work, The only thing is, because they stimulate, remember that the beta cell, part of the pathophysiology of diabetes is that the beta cells are working so hard to make insulin. So this is a drug that makes them work even harder. Okay, so the implication of that is they tend to make the beta cells to burn out even faster. So I generally don't use sulfonylureas. I use them only if there's really no other option, just because of that. Because they speed up, they don't really work in pathophysiology, they just make you make more insulin. So they make the beta cells to work harder, even though they're already working so hard. So that's why, but in the short term, they do make you make more insulin. So they work, but it's just that long term, they're not the best to use. An adverse effect, we talked about, hypoglycemia. And because you make more insulin, you're going to gain weight. So it makes you gain weight as well. Difference between sulfonylurea and glenites. The key difference is their half-life, okay? Sulfonylureas have a longer half-life. Glenites have a short half-life. They're almost like taking a long-acting insulin versus a short-acting insulin. That's the way I think of glenites. So glenites are like for mealtime. They take it before the meal, and they give you a burst of insulin, whereas the sulfonylureas are like once a day or twice a day, and they last all day long. But they work in the same mechanism. Then alpha-glucosidase inhibitor. So this is a class that what they do is they inhibit carbohydrate breakdown in the intestines. Okay, so alpha-glucosidase breaks down carbohydrates in the intestines, and if you don't break it down, you're not going to absorb it. Okay, so that's how they work. They lower postprandial glucose. What medication is in the class? Anybody? Yes, acarbose. So that's the most popular one. Advantage is cheap, it's effective. But the biggest thing about alpha-glucosidase is the adverse effect. Because you don't absorb the carbohydrates, they stay in the stool, and they cause all kinds of gas and bloating. And so that's the most common complaint that patients will talk about, gas and bloating. Then TZDs, these are the PPA gamma agonists. Your glitazones, so the pioglitazone, okay, so that's the most common in the class. And they are very powerful for insulin sensitization. So that's one of the... Metformin has some insulin sensitization effect, but TZDs are very powerful for sensitizing the body to insulin. So that's one of the key mechanisms. We've talked about the pioglitazone and rosiglitazone. Advantage, they're cheap and they're effective. And also one other effect that TZDs have is they move the fat in the viscera. They have a way of redistributing fat from the viscera to the periphery. So that's why they're very effective. They cause changes in the fat processing, that you move fat from viscera to the peripheral fat, and they make, that's probably one of the mechanisms that they cause improvement in insulin sensitivity. The main adverse effect of TZDs is that they do cause fluid retention. That's one of the things. So if patients that have heart failure, you want to avoid the TZDs. All right, then incretins. So the incretin effect, this is just, again, for your understanding. So this is an illustration of an experiment that was done in healthy subjects, okay? They measured insulin level. They gave them a certain amount of glucose, I think 100 grams of glucose orally, and they gave them 100 grams of glucose IV, and they measured their insulin secretion. And they saw that when they gave the same individuals 100 grams of glucose orally, they made more insulin compared to 100 grams of glucose through the veins. It's the same amount of glucose, but because you gave it through the mouth, okay, there was a more pronounced insulin response. So they went to, then they looked at the gut. That's how they discovered the GLP and the peptide YY, all the incretins, GIP and all that. So they found all those hormones, and that's how they found that. But the interesting thing is, in patients with type 2 diabetes, they have a blunted response. So they are, even though they do have, you do the same experiment, they don't have as much of a response, suggesting that patients with type 2 diabetes have less of those incretins, okay? Because of that, that's where the concept of, giving those, GLP-1 and all that to patients with diabetes to improve their response came from. So that's kind of a background. So GLP-1 receptor agonists, they increase you can see that they have a lot more action. This is not even all that they do because we have found a lot more things, but they do increase insulin secretion. But unlike sulfonylureas, they increase insulin secretion in response to glucose. So they're not going to cause if there's no glucose, they won't increase your insulin secretion. Only in a glucose-dependent manner that they increase the insulin secretion. They do delay gastric emptying, okay? And that's part of how they make you feel full. They enhance satiety, through the, pathways in the hypothalamus. And then they suppress glucagon, okay? Remember those pathways that we talked about, the 8 defects, which is even more than 8, but they do suppress glucagon. And then they promote beta cell proliferation, which I think is one of the best things about this class, is that not only do they help the function, they also preserve your beta cells, even longer. Which is why they are very effective in kind of reversing diabetes, so to speak. So the drugs in the class, I think we've talked about some of these: liraglutide, semaglutide, dulaglutide. Those are the GLP-1s. And then tirzepatide is a GLP-1 plus a GIP. It has a GLP-1 and GIP activity, which is, again, they're all incretins, but that's the difference. The main advantage of this class, again, I've talked about this, they affect many pathophysiologic processes involved in diabetes. So they're very effective in countering things like, they have effect on blood pressure, on lipids, and, they have effect on cardiovascular risk. In fact, the GLP-1 class have a non-diabetes indication where if you have history of, cardiovascular disease, atherosclerosis, ASCVD, okay, you can actually be eligible to use it for risk reduction, independent of diabetes. So patients that don't have diabetes, I send my patients that go to see their cardiologist, they don't have diabetes, and they come and they're taking GLP-1s because the cardiologist is prescribing it. They have effects on the kidneys. We talked about nephropathy in diabetes. Patients with diabetes tend to have, kidney disease. The GLP-1s have been shown to reduce the progression of kidney disease, and they have a separate indication, not for diabetes control, but for reduction of kidney disease progression. And many other things like fat in the liver, MASH, MASLD. There's a specific indication for GLP-1s for reduction of fatty liver, fat in the. So there are several indications. So the point of this is not only do they control the glucose, but they do so many other things that are related to metabolic syndrome that it's almost a no-brainer to use them. Adverse effects. The main adverse effect is, of course, the gastrointestinal, GI, nausea, diarrhea, and things like that. Those are the most common adverse effects. Rare but often talked about is, medullary thyroid cancer. But I have like 1 or 2 patients that I know that have medullary thyroid cancer. So it's a rare, thing, but be aware of that if they bring it up, if it comes up, when you're talking about GLP-1 agonists. And then I think this is probably one of the last slides. DPP-4 inhibitors, these are, the way they work is they inhibit the breakdown of endogenous GLP-1s. So that's really, the bottom line is they inhibit, so they try to increase the endogenous GLP-1 available to the patient. Obviously, as you can tell, the patients with diabetes, we talked about this, they have decreased GLP-1 to start with. So even if you're preserving what they have, these are not very effective medications because they're already in a deficient state. Okay, but they do work, but they're not the most powerful agents to use. Their advantage is they're oral, they're pills, they're not injectable, so they're oral, they're cheaper, relatively cheaper, and they don't have a lot of adverse effects. SGLT2 inhibitors, another big group. We talked about, the glycosuria in diabetes, and the point of this slide is to see that the SGLT2 inhibitor, sodium glucose transporter 2, what it does is instead of the threshold for glucose clearance from the kidneys being at 200, it moves it down to like maybe 120. So that once the glucose in the serum goes above 120, you start to excrete the glucose in the urine. You don't have to wait till it gets to 200. So instead of reabsorbing it, the kidney will start to clear the glucose at a lower threshold. So that's how they are very effective. Or they do cause osmotic diuresis. Some of the drugs in the class, things like, what are some examples? SGLT2 inhibitors. They end with gliflozin. So empagliflozin, dapagliflozin, and canagliflozin. Okay? So again, those are the drugs in the class. Again, these are things that, you can't talk about diabetes without talking about these medications, but it's to put in context, and it might help you to remember the pathophysiology we talked about by understanding how these medications work. Advantages, again, they have cardiovascular risk reduction, very effective for cardiovascular risk. They also help with heart failure. Patients that have heart failure, remember that because they have diuretic effect, patients that have heart failure have beneficial effect. They have an indication for reduction of hospitalization for heart failure with or without diabetes. Okay? Of course, adverse effects, one of the key adverse effects is to remember that you can get dehydrated. Also, you can have, because of increased glucose in the urine, you can have infections in the urinary tract because of the increased glucose. Hypoglycemia, I think this is the last topic we talk about. Whipple's triad, that's important to remember. So Whipple's triad is symptoms of hypoglycemia, so symptoms that suggest hypoglycemia. What are those symptoms? Okay, cold, clammy skin. What else? What causes those symptoms? We're going to talk about it, but what's the cause of the symptoms? Why do patients get symptoms when the glucose is low? It's hormonal. We're doing endocrine, so remember, everything is kind of hormonal. So it's caused by hormones, those counter-regulatory hormones. So think about it, okay? But the symptoms, we'll talk about it in the next slide or so. But symptoms of that suggest hypoglycemia, and then when you measure the glucose, the glucose in the plasma at the time of the symptoms is low. And then when you give glucose from outside, the symptoms go away. So that's Whipple's triad. So that's hypoglycemia. This is a classification. I don't think at this point is that relevant. It's just to recognize what is a low glucose. So if you have glucose like in the 70s, that's level 1 hypoglycemia. And then as you develop, the lower it is, the more, the worse, the more severe. But very importantly, if you have symptoms, severe symptoms, it doesn't matter the level, that's already considered level 3 hypoglycemia. And this is the hormonal response to hypoglycemia. So before hypoglycemia, the first response in normal individuals that don't have diabetes, okay, if anybody that doesn't have diabetes here, if you don't eat, okay, the first response is the body will lower the glucose level. So you don't get hypoglycemic. So it will lower it to the level that to match the amount of glucose you're producing, from gluconeogenesis. So it's not very high. So the first step is, which is why we almost never get hypoglycemic, right? I mean, people run marathons and, they do drink stuff along the way, but the bottom line is you burn a lot of calories and you don't pass out because you used up all your calories because the body is generating calories and you're making insulin to match that. But as the glucose continues to decline, okay, again, this is applicable to patients that don't have, that maybe have some pathologic process, like an insulinoma. So insulinoma is when you have an insulin-producing tumor in the pancreas, okay? Then you can have the counter-regulatory response. So that is glucagon, okay, epinephrine, growth hormone, and cortisol. So epinephrine, what does it cause? What symptoms would it cause? Tremors, right? Palpitations. So those are the symptoms of hypoglycemia. And then the sweating, there's some cholinergic response as well. But the goal of the counter-regulatory hormones is to bring back the glucose, to prevent it from going further down. But if you have a process, okay, where you have either exogenous insulin or endogenous insulin that is pathologic, and it continues to go lower, then you can get neuroglycopenic. Okay, so neuroglycopenia is when the brain doesn't have enough glucose to function. And that's when it's, you can get into like coma and seizures and things like that. So that is what happens in hypoglycemia, and that is the normal response. Again, most people don't get to neuroglycopenia just because the counter-regulatory hormones kick in and generate glucose from different sources to keep the glucose up. But if there's a breakdown where the insulin is so much that the counter-regulatory hormones cannot make up for that, then you're going to have, hypoglycemia and neuroglycopenia. Any questions? And this is, more detailed, in terms of hormonal response to hypoglycemia. You can look at this in your slides on your textbook. And when you have hypoglycemia, you check the serum glucose, insulin, C-peptide, ketones, and sulfonylurea. Okay, and this is these are the things that you expect that will tell you about what is really causing the hypoglycemia. Okay. Sulfonylurea is obvious because sometimes patients go to you want to pick up your antibiotic or something, and maybe there's an error. The pharmacist gives you, glipizide instead, and you start having hypoglycemia. So that's why you screen. Some patients, we had patients where the patient takes it, as a way to, get sick, factitious intake of, and this is something that you're going to see in, if not step 1, probably step 2, where they're going to give you a patient that had, hypoglycemia, and you're supposed to decipher, what's the cause. Is it because they took sulfonylurea? Is it because they have an insulinoma? Is it because they are fasting for a long time? Or is it because they took exogenous insulin? Yeah, this is an exercise. If you guys want to, we can go through it. I think this is the last slide. So if you want, it's almost we have about 20 minutes before the top of the hour. So maybe we can go through this. Let's go through the different conditions. So the answers are on the right, the number 1 through 5. And then the conditions are A, B, C, and D. So we can try to, you're going to see stuff like this on your exams, your board exams, your step 1. So you're going to, it's good to get used to these arrows up and down. So you have a condition that has increased insulin, increased C-peptide, and decreased glucose. Which of the options on the right could that be? So increased insulin, increased C-peptide. Remember we talked about C-peptide. So what could that be? You can talk about it, and let's come up with what we think. Okay, insulinoma, do we agree? Okay. And that's because the insulin is high, right? And the C-peptide is high, so it means it's coming from inside. And the glucose is low. So that means that, there's inappropriate insulin secretion causing hypoglycemia. So that is insulinoma. So I'll accept that. How about B? So insulin is increased, C-peptide is decreased, and glucose is decreased. So what could cause that? Okay, exogenous. We agree? Okay, so in this case, insulin is going up, C-peptide is going down, so they're going in opposite directions. So that means they're not coming from the same source. So in this case, yes, our exogenous insulin is a probable option. By the way, for condition A, okay, we'll skip that. We'll come back to that. So C is there's decreased insulin, decreased C-peptide, and the glucose is normal. Fasting. Okay? We all agree? Yes, when you don't eat, the body responds by decreasing the insulin, decreasing the C-peptide, and glucose stays normal. All right, how about D? Insulin is increased, C-peptide is increased, and glucose is increased. Large meal. Okay. So that's normal response. So if the glucose goes up, you make more insulin and C-peptide. Okay. How about sulfonylurea? Which one is sulfonylurea? Which condition could it be? Which of A, B, C, or D? Sulfonylurea. Let's do, I don't want to do table by table. What do you guys think? I heard A from here. A. Last call. A. Okay, so it's A. All right. So that's because you're making more insulin, you're making more C-peptide, and the glucose. Remember, I talked about the only two things that will give you hypoglycemia: insulin itself or sulfonylurea. Okay. So so how do you distinguish between sulfonylurea and insulinoma? How can you tell? Because it's similar, right? They both stimulate insulin production endogenously, causing hypoglycemia. But how do you tell the difference between the two?
Would you be closely monitoring a patient because insulinoma is constantly producing insulin versus an injection?
Okay, I'll take that. Get history. They'll have the same effect on potassium. But I like the idea of thinking beyond just the medication. So in this case, you have to think about, is there something I'm missing? So a history is important. Did you feel any new medications? But also, you can check the sulfonylurea level. You can check the level. What we do that, so you can do a blood level for sulfonylurea, especially if you suspect that maybe the patient either in error or intentionally took a sulfonylurea. Okay? All right, I think we've come to the end. Do you have any additional questions? I know it's a lot of stuff, and I hope that, we'll kind of run through it. But as you study and maybe something comes up, reach out, okay? Tomorrow we'll talk about pituitary. So we'll switch to pituitary tomorrow. I sent the slides already. It's in the file, so you can access those slides as well, okay? All right. All right, thank you.